related to almost all the specialties in medicine, and that is, as you can see, diabetic retinopathy. I was intending to start the retina from anatomy and some other topics, but when I saw your textbook, then I came to know that it is starting from the diabetic retinopathy is the first topic in your book. So I want to go through your textbook so that when you study, it doesn't become haphazard for people. So, as I told you, it is a very important disease. Diabetic retinopathy is a disorder of the retinal vessels that eventually develop to some degree in nearly all the patients with long-term diabetes mellitus. जो लोग डायबिटीज मेलाइटिस जिनको होती है, after 10 years 90% of the people they develop diabetic retinopathy regardless of the hypoglycemic control, whether it is controlled or otherwise. Okay, so keep it in mind, diabetes especially affects the medium and small size vessels and affects the eyes and kidneys the most. Most common cause of bilateral universal visual loss in working age group in United States. I will skip the risk factors. Age at the diagnosis of diabetes, duration, poor control of diabetes, pregnancy, hypertension, neuropathy, hyperlipidemia, obesity, anemia, smoking, cataract surgery. If any one or more of these are present, then the probability of development of retinopathy is increased. No voice. No voice. So, what is the pathogenesis of diabetic retinopathy? Try to understand this important mechanism, how it affects the diabetes. Before going to the slide, let me tell you in simple words. Every endothelial cell in the retinal blood vessels, are you getting me? Every endothelial cell in the retinal blood vessels is supported by a supporting cell which is called pericyte. Okay? So the bottom line is, in what happens in diabetic retinopathy, I'm telling you the bottom line. In between, a lot of things happen, and ultimately there is a loss of pericytes. When the pericytes which are supporting the endothelium, when they are lost, there is no support to endothelium, so it cannot function properly. Therefore, the plasma constituents, blood and other things which are present in the blood, they exudate from the blood vessels, and sometimes oxygen does not go to the right place, and the ischemic factor also gets into play. So this is actually the basis of the pathogenesis of diabetic retinopathy. If you remember these couple of lines which I just talked, if you write these things, these are enough. Number 1, leakage. Number 2, ischemia. Remember these two words. If you write pathogenesis, number 1, leakage from the capillaries. Number 2, ischemia, you will be given the full marks. Now, this slide is the intermediate factors which causes the effect which I just mentioned. Hyperglycemia causes intracellular sorbitol, which is alcohol accumulation, free radicals, and then come direct effect on retinal cells, microangiopathy, damage to capillary wall, the main thing, hematological and other changes, and then see the intraretinal hemorrhages, edema, macrovascular occlusion, and new vessels. These are the consequences of two things which I told you. What two things I told you in pathogenesis? Number 1, number 1, leakage, very good. And leakage from the capillaries. Number 2, ischemia. So now, and this is because of the loss of pericytes. Understood? This is the pathogenesis of diabetic retinopathy. Now what we will learn will be the classification of diabetic retinopathy, and that all will depend on these mechanisms. Now, angiogenic stimulants, vascular endothelial growth factor A, platelet-derived growth factor, hepatocyte growth factor, angiogenesis inhibitor, angiostatin, pigment epithelial-derived factor. These are also the consequence of ischemia. No, one more important thing to remember: whenever there is ischemia in the retina, there will be ischemia is a stimulant for the formation of angiogenic factors, and angiogenic factors cause formation of new blood vessels. Remember this very logical thing. Now, classification. These are normal capillaries. These are pericyte loss. These are histological signs. Now, let me skip this slide. See, microaneurysm. Microaneurysm. This is a microaneurysm. This is the picture of the fundus, the posterior part of the eye or the retina. This is macula, and these right dots are microaneurysms. These are not bleedings. And this is fundus fluorescent angiography. By detecting 10 or 20% fluorescence in the cubital vein, you take with a special camera the pictures at various times, which are called phases, and you can see that these aneurysms are filled with the fluorescence. These are normal blood vessels showing the fluorescence, and these dots should not be present in a normal person, but these are as aneurysms, so they are also filled by fluorescence. And now, what I am going to say next is perhaps the most important thing which you might be asked in exam. the first sign, the first clinical sign, to be more precise, the first clinical sign of diabetic retinopathy is the presence of microaneurysm. Maybe it's one. And even if you are not in ophthalmology, if you are in medicine or surgery or anywhere, you should carry a direct thermoscope, and when you come in eye ward and when you come for house job, try to learn a couple of things from direct thermoscope. Number one, to detect diabetic retinopathy. Number two, to detect papilledema, which is the bilateral disc edema secondary to raised intracranial pressure, not intraocular, and it is always bilateral. Number three, normal fundus. First of all, these things you must learn before leaving the eye OPD. If you are even coming for 1 month or 3 months rotation, wherever you will go, thermoscope, if you buy a small, it's good. Otherwise, it is present in every ward. So that's very important. So microaneurysm is the first clinical sign of diabetic retinopathy. Intraretinal hemorrhages. These are intraretinal hemorrhages are difficult to differentiate from microaneurysm on pictures at least. But this is the second sign of diabetic retinopathy. And you can see they are just like microaneurysm. This is optic disc, and these are, you can see, if you see this hemorrhage, this is flame shaped, as the ganglion cells are like in a crisscross manner, like my 4 fingers. So if the bleeding happens, it will take the pattern of these fingers, and it will appear as a line here, and a line here, and we call them flame-shaped hemorrhage. Okay. Now this is the picture of OCT, optical coherent tomography, which is the latest method. Of checking the preclinical signs which may not be visible. This is normal. This is a normal OCT, and this depression is a macula. Okay, and this is macular edema, and it is forming a cyst, so we call it cystoid macular edema. CM, cystoid macular edema, is very common in diabetic retinopathy. Then now, what are the exudates and how they are different from hard exudates? One are soft exudates, and the other terminology is hard exudates. Okay? These are, as I told you, because of the leakage from the endothelium. the plasma constituents, they consist of cholesterol and lipids, proteins, and these accumulate at various places of the retina, especially in the central. One thing is very important. Diabetic retinopathy affects the central part, central 30°, and retinal detachment affects the peripheral part. So these are the hard aggregates, and soft aggregates, and this is because of leakage. And what happens because of, what was the other thing? Ischemia. Ischemia causes decreased oxygen and it damages the ganglion cell layer, and the ganglion cell layer damage appears like cotton wool spots. We call it cotton wool spots. जिस रुई होती है उस तरह देखने में नजर आता है, white white. So they are called cotton wool spots. They are dead axons caused by ischemia. Now you see, this is normal FFA fundus fluorescence picture, and this is ischemic. You can see this is macula. These are, how we come to ischemia? Because the blood vessels around the macula is normally avascular. The only thing which is telling us that there is ischemia, that around the macula the blood vessels are very tortuous. So leave it for the time. These are cotton wool spots. These are weak only of that. Okay. Till now I am telling you the basics, pathogenesis and basic signs of the diabetic retinopathy, which belong to the first stage of diabetic retinopathy. These all signs. What signs I have told you? Number 1, microaneurysm. Number 2, intraretinal hemorrhage. Number 4, hard aggregate, and not cotton spots. These 3, and plus retinal edema. These form the first stage of the diabetic retinopathy, which we call background diabetic retinopathy. So here ends the first. There are 3 stages of the diabetic retinopathy. Number 1, it is called background diabetic retinopathy, which we just learned. Second stage is pre-proliferative diabetic retinopathy. Pre-proliferative diabetic retinopathy. And the third stage, and the last stage of diabetic retinopathy is proliferative diabetic retinopathy. So now after background diabetic retinopathy, after studying the background diabetic retinopathy, which have 4 signs: microaneurysm, number 1, intraretinal, retina has 10 layers, intraretinal hemorrhages, बिलाल आ गया इंट्रारेट्रल हेमरेजेस नंबर 3 number 4 heart accidents and reactor edema bilal come on now pre-proliferative diabetes before the proliferation the you can see portal spots these are also called soft exudates and you now know I think well the difference between soft and hard exudates isn't it okay what is the difference between soft and hard exudates what is the difference between soft and hard exudates I just told you Salis what is the difference between soft and hard exudates yes ऊंचा बोले excellent and hard exudates leakage what constituents are leaked usually no clapping ये आप लोगों को नहीं आता इस बात पे ताली बजा रहे हैं पूरी क्लास में एक बंदे को आता है और मैं आपको पढ़ा रहा हूँ ये मैं अपलोड भी करूँगा यार मुझे किसी से कंसर्न मुझे अपना काम करना है डोंट गिव मी द रेफरेंस वेरी मच ओके अजान हो रही है दाग बहुत है स्पॉट अब समझ आ गई है जी जी बच्चे कह रहे हैं अजान हो रही है so after bottom spot now intraretinal microvascular abnormalities these are called IRMAs इसको अगर एब्रीविएट करें तो IRMA बनती आज मैं आपके पास ये दो चीज पढ़ाऊंगा इजी नहीं पढ़ाऊंगा लेकिन आप जरा मुझे समझ नहीं आ रही कि इतनी मैं अपनी तरफ से ट्राइंग माय लेवल बेस्ट सभी Dr. Sabi, I am trying my level best, but I am very disappointed by the feedback. Right now, I just told them everything, and immediately after telling them they are flat. What is the reason? What is it? Am I not able to communicate them things in a good way, or they are not interested? What do you think? And they are laughing. Sir, मैं आपसे slow लग रहा है I know each one of them personally, especially Bilal. I know you how slow learner or how fast you are. I know you. If someone else would have said it, I might have accepted it. So don't try to make fun. It's an official class. Don't try to make fun. So you are a medical student. You are not an entertainer. So The intelligence is that when a teacher is studying, whether he is good or bad, the ethics is that the Islam and every religion, or even the atheists and every civilized and even uncivilized societies, all agree that when a teacher is studying, then the student should behave properly. So, first sign of pre-proliferating. I will do my work, I will do my duty. And my duty is not to just deliver the lecture and go away. My duty is to pour and insert or instill these things into your mind by book or by any way. I want these things into your mind. Okay? Then I will be satisfied that I did something better. Okay. This is the second sign. What happens? This picture might not be very clear, but these are like these blood vessels. This is main blood vessels. For example, the branch of central retinal artery, superior branch, and from that some other branches are or it's near its that branch, another couple of branches are present. These are not new vessels. These are intraretinal microabnormalities, and these are because of ischemia. And we will discuss in the last stage in proliferative diabetic retinopathy how we differentiate between IRMA and new vessels, because it makes a lot of difference in the management of diabetic retinopathy. Now, this is the third sign, venous looping. You see, the veins are looped, venous bleeding, जैसे गिरा आ गई है blood vessels में. Venous segmentation, blood is segmented down. Retinal arteriole obliteration. These are all the signs of ischemia. When there is ischemia, then blood vessels become tortuous. They become beaded. And when we see this sign along with portable spots and no new vessels, we reach to the conclusion that it is second stage, that is Arisha, please pay attention. And along with this and the previous two signs, we reach to the conclusion that this is the second stage of diabetes. Now, these are from here starts the proliferative diabetic retinopathy, which we will discuss in the next lecture. Abhi, कोई question? Any question till now? Any questions regarding diabetic retinopathy? Any question? Any question? Any question regarding any topic of diet? Thank you very much.